Thank you for the introduction. It's just Professor Wading showed us the complicated pathogenesis of AIH, autoimmune hepatitis. So for the clinical practice, autoimmune hepatitis, the diagnosis is have many complicated things, including the autoantibodies, score system, and the histology. So I'll talk about this, how to deal with the management diagnosis of autoimmune hepatitis in clinical practice. Autoimmune hepatitis is characterized by the autoantibodies and hypoglobulins and interface hepatitis and histological examinations. The clinical presentation may be acute, severe, or prominent, and many patients have asymptomatic, so it's underground. The diagnostic criteria have been codified, and the diagnostic scoring system can be one of important support for clinical diagnosis. This is show you this different clinical phenotypes of autoimmune hepatitis in clinical practice. They may acute onset. For these part of patients, we have to differentiate it with other acute liver disease, including viral hepatitis, drug-induced liver disease, and other etiologies. About 50 to 75% patients present with acute onset. So this Professor Serene will talk about this acute onset with cause the liver failure. This is a big issue for clinical practice. We know there's no finite criteria for this acute onset diagnosis. Acute severe or fulminant onset is very rare, but it's severe. So for these part patients, we have to differentiate with other reasons. This can resemble with other viral hepatitis, drug-induced, etc. So we have to figure out these part patients from the other reason, because steroid treatment for these patients is very important. From the literature, we can see this, the onset for this acute severe autoimmune hepatitis showing this encephalopathy, and you can see the central lobular necrosis in 86%. This is in our clinical practice. Most patients at the beginning show this central lobular necrosis or inflammation, but we do these part patients as a drug-induced liver injury. I'll talk about later on this topic. And interface hepatitis in these patients may be about 50 to 90%, but some patients lost these figures of interface hepatitis. So it's difficult to diagnose this acute severe autoimmune hepatitis in clinical practice. And some patients have asymptomatic presentations. About 25% to 30% patients show no any clinical signs, including symptoms and even in the antibody, autoantibody. But for these part patients, histological features is important to diagnosis. And for this asymptomatic presentation, these are very low frequencies of resolution if untreated with part patients. So this is these patients, we have to find them from the populations, because the patients asymptomatic can the disease progression even very fast to the cirrhosis. There's this non-classical clinical phenotypes is I mentioned. I just spell. How about the antibodies? for the diagnosis of autoimmune hepatitis. It's very useful, but it's not specific. Just because no specific marker for autoimmune hepatitis so far. There's some standard antibodies for the diagnosis of autoimmune hepatitis. Anti-nuclear antibodies is a centromere, it's a ribonuclear proteins, and it's a kind of complex. But this is very useful, popularly used in autoimmune hepatitis, but it's not specific. There are many diseases have AA positive. So this lacks the organ disease specificity and present 80% of adults with AH. And occurs in 20 to 40 without autoimmune hepatitis. So this is always confuses us that the AA positive and ALT, elevation ALT, whether you can diagnose autoimmune hepatitis or not. So the diagnostic accuracy for AA is only 56% in autoimmune hepatitis. This estimate is that is a smooth molecule antibody. It's a little bit specific for autoimmune hepatitis so far. It's present in 63 in adult autoimmune hepatitis. But it's not very high prevalence in AIH, but its specificity is better in about 96%. And the diagnosis accuracy for autoimmune hepatitis is 61%. So combination with SMA and AA maybe increase the diagnosis efficacy and accuracy just for the clinical practice. Anti-liver kidney mitochondria mechanism antibody is a cytochrome P415. It's an antibody. They present in only 3% in the North American adult autoimmune hepatitis. And detect in the British children is higher. It's about 14 to 38%. It can occur in some other etiology hepatitis, including Hep C, and very low co-incidences with SMA and AA. Only 2% is co-occurrence. This antibody is a very high specificity for the diagnosis for type 2 autoimmune hepatitis, but the sensitivity is pretty low. So for the type 2 autoimmune hepatitis, this is only specific antibodies. There's other non-standard antibodies for the diagnosis of autoimmune hepatitis. But this part of patients we need to do further study on the efficacy, specificity, and the sensitivity. This antibody, anti-actin, there's many publications recent years, is present in 87% in autoimmune hepatitis, concurrent with SMA in 86, even 100 with autoimmune hepatitis. And this is kind of indirect marker for disease activity. So I think we can do further study on this anti-actin antibody in the diagnosis for autoimmune hepatitis, even to predict the liver progression in clinical practice. Another one is alpha-actin antibody. It's similar with anti-actin, but the prevalence is lower than antibodies to actin. And this is soluble liver antigen, and this kind of we use as the type 1 phenotype of the autoimmune hepatitis. This is present in 7 to 22 in AH. And the genetic association is HLA. And this is associated with the severity, response, relapse, and survival. This antibody may be one of the good predictor for the disease progression. The specificity for the anti-soluble liver antigen is 99%. It's a very high specificity, but the sensitivity is low. P-ANCA is a typical prenuclear anti-neutrophil antibody. It can be used in the PIC diagnosis, but in some autoimmune hepatitis, you can see the maybe percent 50 to 92%. There's no further details in these antibodies in AIH, but it can be used as a kind of differentiation antibodies. The antibody to the HLO glycoprotein is we didn't do a lot from the publications. This is kind of is kind of occurred the other acute and chronic liver disease, and this is useful to as a classification seronegative AH. This correlates with the laboratory and histology activities. So this part we didn't do in China, but from the publications you can see this antibody can present 67 to 88% in adult AH. We did this type 1 antibody to liver cytosol. These antibodies can present 24 to 30 in AH and occurred with other hepatitis. This is useful for the classification, but the sensitivity and the specificity is pretty low. In some drug-induced liver disease, you can find this anti-liver cytosol antibody. So this is summarized for the autoantibody in liver disease. There are many overlap. So this is make the autoantibody complicated in the diagnosis of autohepatitis. You can see autoimmune liver disease, many antibody can positive, and where hepatitis is similar things, and other autoimmune disease such as RE and others. So autoantibodies can be used for the diagnosis of autohepatitis, but not very specific, and the sensitivity is need to be further studied. There are some patients with no autoantibody. This part of it is tough for the diagnosis in clinical practice. Patients with typical clinical and laboratory findings of autoimmune hepatitis, but the autoantibody may lack. About 1 to 5 autoimmune hepatitis without autoantibody in the serum. So for this part patients, it published in British patients, about 7 patients, and in Japanese is 24% is in acute severe diseases. This is maybe from the pathogenesis we can understand with the severe disease have the very active immune reaction. So maybe the antibodies, including CTLs, T cells, and the B cells, may be less. So the antibody production may be reduced. The revised organ scoring system in this situation may be useful to figure out this is autoantibody negative phenotypes. Overlap, this another typical phenotypes of autoimmune hepatitis, including overlap syndrome. Overlap syndrome is very common in clinical practice, but difficult to the diagnosis. You have to do the many differentiation things. The overlap syndrome is a kind of distinct entity of this own. For example, for autoimmune hepatitis and the primary biliary cholangitis overlap syndrome is kind of sometimes it's features with autoimmune hepatitis, sometimes the PBC. So the overlap syndrome is always together. So this is make the clinical practice more complicated. And that recent year, drug-induced autoimmune hepatitis is very popular, and many studies showing that drug is one of reason for the acute autoimmune hepatitis. Especially, there's some antibiotics and statins recent years showing that can cause the autoimmune hepatitis. But for the drug-induced AH, it's difficult to do the differentiation because they have the drug use and experience and have some autoimmune liver hepatitis features, including the interface hepatitis, lobular inflammation. Is from the histology, pathologist, lobular necrosis or inflammation is one of the features of drug-induced liver disease. But recent publication showing that the lobular necrosis may be one of the type of the autoimmune hepatitis. How about the diagnostic criteria and the scoring system? Because there is no specific marker, so scoring system is important for this kind of thing, disease diagnosis. I will not say details. This is a reverse original scoring system, and this is simplified diagnostic criteria for the diagnosis of autoimmune hepatitis. This is simplified score system is very useful for Chinese patients. Professor Ma from Shanghai published the study. You can see the performance of this score system is not bad for the diagnosis of autoimmune hepatitis. But you can see the sensitivity is good. It's comparable with the original one and the simplified one. But the specificity is, it seems the simple one is better compared with the original one. And this is Professor Ma's group. It's publication in the Journal of Hepatology, showing in Chinese patients it's good for the diagnosis of AH. But it still have this something is not solved. You can see this is a defined AH. It's about for this part of patients, score system with a simplified it's about 60% is definite AH, and others may multiple one and other case. So scoring system it still has the limitations when we use in the diagnosis of autoimmune hepatitis. It's one of the tools for us. So there's many limitations for diagnosis scoring system. These have been the characteristics have not followed the predefined protocols. It's just a proved experience have been limited, and we need to do the prospective clinical study for this score system. How about this histology? Histology is interface hepatitis. It's a typical one, and Professor Wenning mentioned it's a rosette and plasma infiltration is a typical features of autoimmune hepatitis in histology. But recent year, some publications showing that this is not enough. The typical histological pattern, this is what I'm very interested because from clinical practice, many patients have this central lobular zone 3 necrosis, but we diagnose it as a drug-induced liver disease. But for the literature from Japanese study, this central lobular necrosis may be a kind of features of autoimmune hepatitis. You can see this from the central zone necrosis without evidence for portal inflammation and interface hepatitis. And this may be accompanied with portal inflammation and interface hepatitis. So for this pathway, we need to do further study on it. I will conclude my talk. Clinical spectrum IH is widely distributed and lack diagnosis specificity. The conventional autoantibodies may be absent, and some autoantibodies, including antibody to LC1 actins, we need to do the further study, may be useful for the diagnosis in the future. The clinical presentation is working with the make the AH more easy and to management. The prospective clinical study are necessary to validate the scoring system. The central lobular necrosis is worth to study for AH diagnosis in the future. Thank you for your attention.